Okay, good evening, everybody. Welcome to the Good Hormone Health webinar entitled Dr. Friedman's Update on Medical Treatment for Cushing's Disease. And happy Easter, everybody. This will be recorded for the people that missed because of Easter obligations. They can listen to it later. Today, we're going to discuss the following topics: why use medicines to treat Cushing's disease, what medicines to use to treat Cushing's disease, side effects and timing of medicines, the use of ketoconazole for a medication trial before surgery, longer-term treatments for Cushing's, and how to determine when a patient should go to surgery. So transsphenoidal surgery, I looked this up, I was sort of interested in this. Everybody thinks it was discovered by Harvey Cushing. However, it was really discovered by Schofield in 1907. Transsphenoidal means approach through the pituitary. And actually, Harvey Cushing did it in 1909 for a patient with acromegaly. He used this to get to the pituitary. But in the 1920s, Harvey Cushing and others seemed to abandon it for more of a transcranial approach. And then it's made a renaissance in the 1960s. And here's a picture of going through the nose and removing the tumor. The endoscope was introduced by Gerard Gouillet in the early 1960s. In the beginning, the endoscope was mostly used as a microscope-assisted tool to explore the cell cavity for residual tumors. In 1997, the first clinical series of purely endoscopic pituitary surgery was reported by my colleague, Dr. Joe at University of Pittsburgh and Carew. Dr. Shahinian also published it in the late 1990s, another colleague of mine. And since then, many pituitary surgeons have gradually shifted towards an endoscopic endonasal approach for pituitary adenomas and other tumors. So surgery versus medical therapy. We've talked about the surgery. It goes through the nose, takes out the tumor. Sounds great. But even in the best series, the cure rate is at the best 70%. That means 30% people don't get cured by it. And I work with the best surgeons in the country, I can say that. The cure rates are still pretty low. I think it's sort of around that 60 to 70%. My patients have a smaller tumors. They may be harder to resect. Tumors are often not encapsulated, and they're like an octopus with 8 arms. And many patients need either a second or third. I've had some patients that had a 4th surgery before they're cured. And the surgery is, taxing on the body. You fly into where the surgeon is. I usually use Dr. McCutcheon a lot in Texas. He's a great surgeon, but, it's still difficult to get there. There's issues most of the time. Insurance covers it, but not always. And, it's taxing on the body, and you get complications. So growth hormone deficiency following pituitary surgery is quite common. I would say a good half to a third of my patients develop growth hormone deficiency. And central hypothyroidism, hypogonadism, both in males and females, diabetes insipidus, where you urinate a lot, and even in some patients, adrenal insufficiency can occur. Somebody needs to be muted here. Maybe somebody on Facebook, Tiffany, needs to be muted. I don't know. A lot of background noise.
Oh.
So the surgery has some downsides to it. It works well. In many patients, it's curative, but not every patient. And on the other hand, medical therapy has advanced in the last several years with many drugs to choose from. And the drugs can be used individually or in combination. And I do have a lot of experience with using medicines to treat Cushing's. I use what I call tricks to optimize the medical therapy. And it works quite well. So I think the issue about surgery versus medicine, it needs to be revisited. And that's what we want to do tonight. I've had one patient on ketoconazole for 12 years. She's a lawyer. I think I started treating her maybe when she was about 19, and now she's like 31, doing quite well on it, no side effects. And many patients are on it for many years without side effects. And I think, again, using some of my tricks, you minimize the side effects, the timing is crucial, and patients do well. And then you don't have to worry about flying for surgery, insurance coverage, post-op issues, all those things of the surgery. So I do advocate preoperative medical therapy, and for several reasons. I've been doing this for years, and the more I use it, the more I feel it's the correct way to go. First of all, it can help you figure out how much the patient's symptoms are due to high cortisol. Not everybody that has some high cortisol have their symptoms due to it. And before you send somebody to surgery, you want to make sure that by lowering their cortisol, which is what would happen in surgery, their symptoms get better. So I use it as a trial. You want the patients to be eucortisolemic, have normal cortisol prior to surgery, then they're healthier. They have less complications such as blood clots and wound healing problems if their cortisol is normal than if it's high. And I give ketoconazole up to the day before surgery. The other thing it does is there's this issue called cortisol withdrawal. And I went to the endocrine side. They had like a whole seminar session on it. They talked about how you're going from sort of high cortisol to normal or lowish cortisol post-op. And they said it's real, it's common. But nobody beside me suggested why don't you give them medicines before surgery to decrease that so they're not going from quite so high to more than a normal level. But I think once I said this in front of some of the Cushing's experts around the country, I think their eyes lit up and they think they're going to start doing it. We'll see. The only downside of it really is it's harder to see a drop in cortisol post-op. So in the old days of high cortisol, sustained high cortisol before I started treating episodic patients, you would look for a low cortisol post-op, and that would indicate a cure. Most of my patients are episodic. It's hard to see. I don't see that much of a low cortisol anyways, so it's not that important. But it does decrease that drop, which could most of the time is good. I still put most of my patients on hydrocortisone post-op, and a couple of them I haven't. I sort of gotten burnt, or they gotten burnt because then they get later down the road, they get adrenal insufficiency. So I do put patients on it, but I think they need it less post-op if they're on ketoconazole. They need a lower dose, and they can get off of it faster if they're pre-treated with a medicine like ketoconazole. So I really think this is the right way to go. And I think as the years go by, I think some of the other doctors are going to sort of recognize this. So what are the medical treatments for Cushing's syndrome or Cushing's disease? Again, we're mostly talking about most of my patients are Cushing's disease, pituitary tumors. Many of these work in adrenal Cushing's as well, although I don't have that many patients with adrenal Cushing's that I treat with this, partially because the surgery is probably more easy and straightforward. So ketoconazole is the one I use the most. I think it's the best. It's inexpensive. It doesn't need pre-authorizations. It works well, has a short half-life, and I'll talk about some of its pluses. It's really my favorite medicine for Cushing's. The second one I use a lot is called Isturisa. The generic name is Osilodrostat. That's why I call it Isturisa. Neither of them are easy to pronounce. It works, but increases cortisol precursors. It's really the same compound as an older compound called metiraprone. They just repackaged it, raised the price, and it blocks the 21-hydroxylase enzyme. Another interesting medicine is called Recorlev. It's the levo-enantiomer of ketoconazole. I'll show a picture of that in a second. So it works like ketoconazole, but because they changed it a little bit, they got a patent on it, and they can charge higher prices. We'll talk about that. The next one is called Korlym. It's made by a company called Corcept. I'm pretty friendly with the owner of the company, Joe Bellani. And it's used to be called RU-486. It's the same medicine that is actually called mifepristone that's used for medical-induced abortions. It's used in a different dose here. It can give you adrenal insufficiency. It's hard to monitor the adrenal insufficiency. It's hard to correct the adrenal insufficiency. So I use it a little less. Cabergoline works modestly. It has little side effects, but we'll talk about that. So the ones that have a star I'm going to talk about today, Pasireotide is a somatostatin analog. It works poorly and gives almost everybody hyperglycemia or diabetes. So I don't use that at all, and I'll show some data on why I don't use that. There's a medicine called aminoglutathione. I don't think it's available now. I haven't seen it. Mitotane I use for people with adrenal remnant tissue, which I have, I think, 2 patients on it. It's very hard to swallow. It's a big pill, has a lot of side effects. It can give you permanent adrenal insufficiency. I rarely use that except for adrenal remnant tissue. And then there's a medicine called trilostane that can be given IV, but I don't really use that much either. Now, this is the pathway from my chapter in Cecil Essentials of Medicine, where I wrote the adrenal chapter that shows cortisol synthesis. So you start with cholesterol, it goes to pregnenolone, and then you have the pathway that generates the mineralocorticoids, the ones that regulate your salt. It goes from pregnenolone to progesterone to 11-deoxycorticosterone, or DOC. That's also a mineralocorticoid. It raises up your blood pressure. Then you have corticosterone, and then you have aldosterone. So this is the mineralocorticoid pathway. The glucocorticoid pathway is one down. You go from pregnenolone to 17-hydroxypregnenolone. Then you go to 17-hydroxyprogesterone. You go to 11-deoxycortisol. That's also called compound S. And then you get cortisol here. So you can see that enzyme number 5 is the 11-beta hydroxylase enzyme that is inhibited by hysteresa in the asterisk. I'm sorry, in the hatch mark, the check box right here. And then you have the enzymes that are inhibited by ketoconazole. So ketoconazole also inhibits the 11-beta hydroxylase enzyme right here. It inhibits the 21-hydroxylase, which I think I said incorrectly before. The 21-hydroxylase is here. That's the common enzyme in congenital adrenal hyperplasia. So the ketoconazole doesn't really inhibit that enzyme. It inhibits this enzyme here, the synthesis from cholesterol to pregnenolone, from pregnenolone to 17-hydroxypregnenolone, and from androstenedione to testosterone. So when you use ketoconazole, you get less of these cortisol precursors over in here, and you block cortisol. When you use hysteresa, you get a buildup of these precursors over here, and that can lead to hypertension and drives you to testosterone. The ketoconazole also blocks the testosterone, which is the beneficial in most of the time in women, may be detrimental in men. We'll talk about that in a second. So again, the ketoconazole blocks multiple steps in cortisol synthesis, and the hysteresa blocks basically this one step here. So ketoconazole is off-label use. It's not FDA approved for Cushing's in the United States. It's approved for fungal infections, but it is the equivalent of FDA approved in Europe. It's widely used in the United States. I wouldn't worry that it's not FDA approved. And it works by blocking several steps in cortisol biosynthesis. There's some studies that suggest it may inhibit pituitary cell growth, which could make your tumor smaller. I don't see that much of that, but it's sort of an interesting idea about it. It has a short half-life. So this means the medicine is gone in several hours, 6 to 8 hours. And I take advantage of this because Cushing's disease is a disease of high cortisol at night. So I give my ketoconazole at night. And therefore, it blocks the cortisol at night when it's supposed to be low. And in Cushing's, it's inappropriately high. It doesn't have that much effect on the daytime cortisol, which you don't want it to affect. So giving it at night, I think, is definitely the way to go. The main side effect is elevation of liver function tests, or LFTs, ALA, AST, and ALT. And these are reversible in stopping the drug. The liver test abnormalities are more pronounced at higher doses greater than 1,200 milligrams. So I recommend checking the liver function test at baseline in every 2 to 3 months. And we'll talk about some tricks also to protect your liver so these don't happen. I very rarely get this to happen, partially because we use a fairly low dose and partially because of the other medicines we use to protect the liver. There's some suggestions that it increases the QT interval. This is on the EKG between the Q wave and the T wave. But there was an article showing that it didn't do that. It was like a theoretical concern. But when they actually checked patients on ketoconazole, there was no effect. So I really don't worry about that. So Cushing's syndrome or Cushing's disease is a disease of high nighttime cortisol. And some patients even have actually sort of lower daytime cortisol. What I normally start with is I give the ketoconazole 200 milligrams around an hour before bedtime or 8 p.m., let's say for most people, and then 1 hour before bedtime around 10 p.m. for most patients, and then 3 hours before bedtime around 8 p.m. to decrease the nighttime cortisol. You can go up on that nighttime dose. Occasionally, I would add a second dose at lunchtime if you're like high in the afternoon. 1 or 2 patients I have on some morning dose, but again, we want to keep people's morning cortisol the same. We don't want to lower their morning cortisol for most people. And you can go up in the dose if the hypercortisolemia is high. I usually use 1,200 milligrams as the sort of maximum dose I use. I call in 5 milligrams of hydrocortisone to be taken in the morning if and only if a patient has symptoms of adrenal insufficiency, nauseousness, vomiting, diarrhea, abdominal pain, achy. I like patients have it on board, but very few people need it. Most people, the ketoconazole only affects the nighttime cortisol and doesn't lower the morning cortisol too much. So most people don't need it, but I like to have it on board. Some people I have take a half a pill, some people full pill. Rarely people need to be on a little higher dose. It's good to have on hand. The other thing I do, which I think has turned out to be a good choice, is I give people, every patient on it, vitamin E, 400 units a day, and milk thistle, which is the over-the-counter supplement that's known to help protect the liver. It has an active ingredient called silymarin in it. So the dosing is usually based on the silymarin. I have them take 1,000 milligrams of silymarin, and this helps protect the liver. So when I do these pre-treatments or concubine treatments, I only rarely see increase in the liver function test. And ketoconazole works in almost all patients. I do educate patients about adrenal insufficiency, but rarely get it. It interacts with drugs, especially the statins, but not that often. So if the maximum dose of, let's say, Lipitor is 80 milligrams, if somebody is on 40 milligrams of Lipitor, sort of like the equivalent, they're getting 80, it's still within the therapeutic dosing. So it's really not much of a problem. There are some indications, some interactions that are theoretical. One patient said she read you can't take it with Tylenol. That's certainly not true. Some of the benzodiazepines there's an interaction with, but most of these are not that clinically significant, and they can be changed by either changing the other medicine or just watching carefully for side effects. I use it, as I mentioned, to help determine how much of a patient's symptoms are due to high cortisol. It's used to get the patients feeling healthier prior to surgery. I give it up till the day before surgery. It decreases that drop in cortisol post-op. Even patients with an adrenalectomy, I use it before because it decreases the amount of drop in the cortisol, the symptoms of low cortisol, and it may decrease the hyperplasia seen on pathology in some patients with an adrenalectomy. So I really like to use it before surgery to get the patient to be eucortisolemic. I usually monitor mostly symptoms. We can check the urine-free cortisols. I have some patients that check them religiously. Some people don't check them that much in. I don't recommend checking the 17-hydroxysteroids or cortisone, which Quest runs, because that is often built. Those are the precursors that go up with the ketoconazole, so I don't check them. Serum cortisol and ACTH, I like to check. The ACTH should go up. That means it's working. And I think the people that have a more sort of a rise in their ACTH are more likely to really be benefit from the med, to have true Cushing's. But a few patients, I don't see that much of a rise in the ACTH. I usually monitor liver function tests every time patient sees me. We start with 2 to 3 months or so. I can move it. Usually 3 months we monitor it. I use it a lot in patients that the pituitary tumor is not that clear. I like to send somebody to surgery who has a clear pituitary tumor. My surgical colleagues see the tumor. Those patients do better. So I have patients that we don't have a clear tumor. We treat them medically with a medicine like ketoconazole, and then we look for the pituitary tumor to come up. I think sometimes it might come up with time, but sometimes it doesn't. I think this is really the best drug, and if you're doing a study, I think you should compare this to the newer drugs. But because this is off patent, a low-cost medicine, that's probably not going to happen. Ketoconazole does lower testosterone, which is probably good in women. Most women have, especially overweight women, have high testosterone consistent with PCOS type of symptoms. So it does lower the testosterone, which is probably good in most women. It may be detrimental in men, but I don't see that much of a problem with it in men. If I do see it, I can put them back on testosterone if needed. Some endocrinologists say ketoconazole is a dangerous drug and should be used in those with severe Cushing's. I don't agree with that. Ketoconazole is safe, main side effect being increased liver function tests, which usually occur at higher doses, greater than 1,000 milligrams, and are reversible. It does interact with a lot of drugs, but these interactions can be dealt with by changing the other drug or watching for side effects. It has a short half-life, so it can be given at night when cortisol is inappropriately high in Cushing's patients. And I usually start with 200 milligrams at say 8 and 10 p.m. and have the patients prescribe, but not necessarily take 5 milligrams of hydrocortisone in the morning if needed. Some endocrinologists say ketoconazole should be used only in those with confirmed Cushing's. I think it's very helpful to determine diagnostically how much the patient's symptoms are due to high cortisol and how much are not. I use it in patients I'm pretty sure have Cushing's, but I'm not completely sure. I want them to start feeling better. And I'm concerned if somebody doesn't get better on ketoconazole, they may not really have Cushing's. I've kept patients on ketoconazole for up to 12 years without problems. I can often stop it for a round of testing. And, one endocrinologist that was trying to treat someone with Cushing's, he wanted the patient to stop it for 3 months. They just don't understand how ketoconazole works. It has a short half-life. So 2 weeks of stopping it is plenty to get it out of your system. And then, if a patient does develop a tumor on MRI, we can reconsider surgery. if I want to do some more testing on somebody, I would stop it for 2 weeks, do the testing over a 2-week period, and then restart it again. So I want to talk about Recorlev or Levo-ketoconazole. It's made by a company called Xeris, Xeris Pharmaceuticals. It's an enantiomer of ketoconazole. So enantiomer means it's like right-handed versus left-handed. This is left-handed versus right-handed, I think would be a better way to describe it. And there's this bond here in the center here with this S here. And you can see it's sort of like a mirror image of the Levo-ketoconazole, the mirror image of the other one that's inactive. So the idea is you're just giving the active form of the ketoconazole, so potentially you can use half of the ketoconazole. But why bother? Just give more of the ketoconazole. It's substantially more potent in cortisol synthesis than its dextroisomer, the other one that's not used. And it might, according to the company, allow for a lower dose of levo-ketoconazole to achieve the same efficacy as currently utilized dose of the racemic ketoconazole. Racemic means it has both the levo and the dextro. Recorlev's starting dose is 150 milligrams twice a day. It should be taken according to the website with or without food. The maximum dose is 1,200 milligrams, and it can be given at 600 milligrams twice a day. They don't really get that ketoconazole and these medicines should be given at night. So I don't agree with that. But 150 milligrams is less than the 200 milligrams of ketoconazole, so just give the 200 milligrams of ketoconazole, I think. According to their website and their brochure, the most common side effects associated with the Recorlev include nausea, vomiting, increased blood pressure, abnormally low potassium levels, fatigue, headache, abdominal pain, and unusual bleeding. Somewhat similar to ketoconazole, potentially maybe more so. In their studies of those patients who endomized or randomized withdrawal phase, significantly more patients taking Recorlev achieved normal urine-free cortisol than placebo. It's a small study. 52% had normalized. That seems a little bit low to me, actually. I think most people should normalize. These patients may have had high urinary cortisols to begin with in some of my patients, while 6% of placebo patients received normal cortisol. The advantage of it is it's FDA approved. It has a support group called Panther, and one of my colleagues at Charles Drew was a Black Panther in the 60s, so I sort of like that it's called Panther. It requires a pre-authorization, which may be hard to get. It may have less side effects than ketoconazole, but this really hasn't been tested. There hasn't been any studies comparing ketoconazole with Recorlev. It's expensive, so I'm not sure if insurance companies may cover it. And I tried one patient on it, I think, but she never really sort of followed up on it. I haven't really found the need to use this over ketoconazole, which is low cost and easy to obtain. We'll go on to Isturisa. Isturisa is also called Osilodrostat. It works the same as the compound metiraprone, blocks the 11-beta hydroxylase enzyme, which is a rare type of congenital adrenal hyperplasia, same as metiraprone. You get a buildup of cortisol precursors, which doesn't happen with ketoconazole. It can lead to high testosterone in women that leads to extrafacial hair, acne, hair loss in irregular periods. It can lead to low potassium because it's a buildup of the mineralocorticoids, which raise your blood pressure and lower your potassium. It can give you hypertension. This is mostly that 11-DOC compound. So I always add ketoconazole back unless the patient has like an allergic problem or liver function test with ketoconazole. Most people that I use Isturisa, I also use it with ketoconazole. Most women should go on spironolactone, which lowers your mineralocorticoids and lowers your androgen. So it's a good drug to use with and raises your potassium. So it's a good drug to use. Spironolactone, it's a good drug to use with Isturisa. Isturisa is available in 1 milligram, 5 milligram, and 10 milligram doses. I usually start with 2 milligrams at bedtime, and then I go up to 2 milligrams at 8 and 10 p.m. or so. The maximum dose is usually 15 milligrams. I think occasionally you can go up to 30 milligrams, but I think the recommended dose is 15 milligrams. The company recommends an EKG at baseline every year, but I don't do that. I don't think that's needed. It's expensive. Insurance companies may not approve it. There is a support group called Novo that will cover it for most patients if it's not covered by their insurance. So that is a good option. I would say it's my second choice other than the ketoconazole. So a lot of times I use the two together, and I think we're going to more and more endocrinologists are going to use these medicines together. They work nicely together. The ketoconazole lowers the testosterone and other precursors. I still give both at night, and I still watch adrenal insufficiency. In general, Isturisa might be a little more potent than ketoconazole, so you might see more of a drop in cortisol with Isturisa, but you watch for adrenal insufficiency, and most people don't get it. So again, I'm pulling up this chart again here. Again, the Isturisas in this hatch mark thing. That's sort of the greenish blue, blocks this one step number 5 here. The ketoconazole blocks the ones in the red asterisk, much more steps. The next medicine I'm going to talk about is cabergoline. Cabergoline is a medicine used for prolactinomas. It's a D2 receptor agonist. The doses you can use vary between 0.5 milligrams and 7 milligrams per week. It's usually given twice a week, and I think a reasonable dose might be 1 milligram twice a week. Studies have found that it leads to biochemical remission in about 30% of the patients, so it doesn't work that well in that many patients, but it works in some. Side effects include nauseousness, headache, dizziness. There's some issue of cardiac valve pressure, valve fibrosis that was seen in higher doses used for Parkinson's disease. It's usually not a problem in the doses used for Cushing's disease. It is an off-label use of the drug. And I have one patient who I'm very fond of who used ketoconazole plus cabergoline for years. She did well on it. She lost 100 pounds or so, got pregnant, and named her daughter Theodora. It's a nice story of cabergoline. The next medicine we're going to talk about is Corlem or mifepristone. Mifepristone is a glucocorticoid and progesterone receptor antagonist that can ameliorate the signs and symptoms of Cushing's syndrome. It blocks the cortisol, the glucocorticoid, and the progesterone receptor. Because of its effect on the progesterone receptor, it's used for chemical abortions. And it's at a lower dose, actually. The dose is usually 300 to 1200 milligrams, and it has a very long half-life. So you can't give it just at night like you can with the ketoconazole or the Isturisa. It blocks the cortisol at the receptor, so you get high cortisol levels and high ACTH levels. And therefore, you can't monitor it with like looking at urinary-free cortisols because they're always high. You can't look at blood cortisol. You can't look at blood ACTH. So the way you monitor and the way it's FDA approved is for people with hypertension, hyperglycemia, diabetes, that you can base the dosing based on the A1C or the blood pressure. So therefore, it's much harder to monitor. It's harder to correct. It's hard to see whether people need more of it. And even though I like the owner, I don't use this medicine that much because of this trickiness. I had a patient when I was in the NIH when we were first discovering this medicine. Every weekend she would get adrenal insufficiency, and I would have to go in from my house and somehow try to give her more glucocorticoids. It was very hard to do. So the symptoms of it are the symptoms of cortisol insufficiency, fatigue, nausea, vomiting, arthralgia, and headache. You can get increased mineralocorticoid effect because it only blocks glucocorticoids. So you get hypertension, hypokalemia, low potassium, and edema. And you get anti-progesterone effects, endometrial thickening, excessive bleeding. Many patients have to have a hysterectomy. So it has a fair amount of side effects from it. It's very difficult to use. It cannot be used with ketoconazole, which makes it really unfortunate because they both affect this P450 enzyme. So I use it much less than other medicines, but I would still say it's my third choice, but I don't have too many patients on it. They're working on a medicine called Recorlev. It's a more specific glucocorticoid receptor antagonist, so it doesn't have the progesterone effects. It's probably not going to have the detrimental effects on the uterus. It's supposed to be approved in 2024 if all goes well. The next medicine is Pasireotide or Signifor. It's a somatostatin receptor ligand, so it works on the pituitary. It is FDA approved. A trial of 162 patients, a good number of patients, showed that a dose of 600 micrograms or 900 micrograms twice a day, it normalized UFC production in 15%. That's really low of the 600 microgram dose, and 26% of those receiving the higher dose, 900 micrograms. Hyperglycemia had 73% of the patients. So 73% either got diabetes or worse glycemia. That's the last thing you want to give somebody. And 92% had side effects. So because it doesn't work well and has a lot of side effects, including issues with the gallbladder area, people get like this gallbladder sludge. I really don't recommend using this medicine. So this summarizes the table of the medicines. We talked about this, but basically ketoconazole is generic, not FDA approved. blocks several steps in the cortisol synthesis. Start at 200 milligrams at 8 and 10 p.m. and work your way up to 1200 milligrams. Side effects increase, transient increase in liver function tests, decreased testosterone levels, and adrenal insufficiency. Recorlev is the L isomer of ketoconazole. Start at 150 milligrams at 8 and 10 p.m. Can updose up to 1200 milligrams. Similarly, similar side effects of nausea, vomiting, increased blood pressure, low potassium, fatigue, headache, abdominal pain, and unusual bleeding. Isturisa blocks the 11-beta hydroxylase enzyme. Start at 2 milligrams and can go up to 2 milligrams. At 8 and 10 p.m., you can go up to 15 or 30 milligrams. Side effects include high testosterone, which is extrafacial hair, acne, hair loss, irregular periods, low potassium, and hypertension. Cabergoline is generic. It's a D2 receptor agonist. You can go up to from 0.5 to 7 milligrams. Usually give it twice a week. And you can get nauseousness, headaches, and dizziness on it. Mifepristone or Corlem is a glucocorticoid receptor antagonist. Doses are 300 to 1200 milligrams a day. Side effects include cortisol insufficiency, fatigue, nauseousness, vomiting, arthralgias, headaches, mineralocorticoid effects such as hypertension, hypokalemia, and edema, and antiprogesterone effects, which would be endometrial thickening. And Pasireotide is a somatostatin receptor ligand. Side effects include diabetes, hyperglycemia, and gallbladder issues. So we have a fair number of medicines, and I think they're going to have a lot more coming up soon. So who should get these medicines versus go for surgery? And I think this is an evolving area also that I think is a crucial question. So again, I start people out on the medicines. If people get a side effect on the medicines, I had 1 or 2 people get a rash in the ketoconazole, 1 or 2 people get it up in the liver tests. So you have to, maybe in those patients, you'd have to stop it. You could try a different medicine. The second thing is medicines no longer work, especially in combination. People are feeling still hypercortisolemic. They still have their stretch marks, their buffalo hump, they're wired at night, their poor sleep, things like that. And I tried combination therapy, it's still not working. So that surgery would be an option. And many patients want a more definitive treatment, and they're willing to take the risk that the surgery may not work versus the medicine that's a good chance is working. So it is a patient-dependent decision that I try to make with my patients. What does the future hold? I think most patients with Cushing's disease will initially be treated with medical therapy. Single or combination therapy will be used by Cushing's experts. Medicines will be used to see how much the symptoms are due to hypercortisolism, to get the patient ready for surgery, prevent the post-op cortisol drop. Medicines will be used long-term. Those that have breakthrough or have side effects will be offered surgery. Many patients want to stay on the medicines long-term versus some will want to do surgery. Many patients with more borderline workups will be treated. I think currently the Cushing's community, maybe rightfully so, before they send somebody to surgery, wants very definitive workups. But to put a person on medicine that's pretty benign, like ketoconazole, I don't think you need quite that as impressive workup. And then later you can do more testing for the surgery. And I think the number of medicines will expand. This was from the consensus statement. I talked about this a couple of years ago from the Endocrine Society. They said future topics ranked of highest important treatments of Cushing's disease determine clinical benefits of restoring the circadian rhythm, potentially with a higher nighttime medication dose. And I've been doing this for years. Medicines for lowering cortisol should be given at night. I'm not sure I see another way out of it, particularly. So we'll open this up to the chats on both Facebook and on Zoom. The talk will be posted on my website in a few days under the webinar section. This is the YouTube channel. You can search Dr. Friedman on YouTube and it'll be there. It will be also on our Facebook page. We encourage people that want to use these medicines that have Cushing's disease to book an appointment with me, tell your friends about it, be on the chats, and try to encourage people to not be frustrated by the lack of their outside endocrinologist that doesn't want to do anything. These medicines are a great option. I have patients, probably a couple hundred patients on these medicines that are doing quite well. Okay, so Lauren stats, for those who already have elevated liver enzymes, is surgery the best option? I think it depends on how high the liver function tests are and if they tried something like vitamin E in the past. So let's say the cutoff of liver function test is 30. If somebody's under, say, 60 or 70, I think you can start the ketoconazole and give them the vitamin E and the milk thistle and watch them closely. Um, Isturisa probably has less elevation of liver tests than ketoconazole does. So a patient like that, you might want to try Isturisa. Corlym also doesn't affect your liver function test. So I think for the patient with the elevated liver function test, it sort of depends on the patient, but I don't not necessarily have to go for surgery. How long does it take for the medicines to start working? Jeannie asked. Soon. They work pretty quickly, within a couple of weeks. Some patients would say the first night they took it, they felt better. I would give it a couple of weeks, but they work pretty quickly because they block cortisol synthesis rapidly. iPhone 3 says, can Isturisa be used like ketoconazole? So both ketoconazole and Isturisa, I do usually put most people on a sort of stable dose. Occasionally, I have people updose the dose when they're in a high and downdose the dose when they're in a low. Some people, like, for example, during a certain part of their cycle, they might be cycling high, and then you can updose the dose. But most people I have sort of on a baseline dose. Sharon asked, theoretically, would a high dose of ketoconazole, like 1,000 milligrams, send a normal cortisol person into crisis? I haven't done that experiment yet, but I think so. The fact that if you give it at night, you're blocking cortisol at night, so it doesn't do as much as if you gave it during the day. But I think people would not feel that well, and potentially if their cortisol could drop and they could get adrenal insufficiency. They may compensate from it. They might, when you block your cortisol synthesis, your ACTH goes up, and a normal person may have enough ACTH, and their ACTH can go up that they won't go into crisis. Is there any downside to starting ketoconazole on a patient that does not have Cushing's? I think that's sort of the same question. People can get adrenal insufficiency. I usually don't, it's a drug to treat Cushing's, so I usually only give it in patients that have Cushing's. People should do enough testing that I think we can figure out that they have Cushing's or not. And I think those are the patients that should get it, not just somebody that has, not fatigue or weight gain, for example. I think I've tried it, again, some patients are sort of borderline and wasn't really sure, and usually does better in the patients that really have Cushing's than the people that don't have it. But, I really try to give it in people with Cushing's. Allison asks, is Isturisa used and effective no matter where the source of Cushing's comes from? That's also a good question. I would say yes. Patients with ectopic Cushing's, which I don't see too much, can have very high cortisol. So the medicines may need higher doses and may not make much of a dent in them. Patients with adrenal cancers that have high cortisol, the same thing, you may need higher doses. But because it blocks cortisol synthesis, it doesn't block cortisol synthesis in somebody that has an adrenal tumor, somebody that has pituitary Cushing's, and potentially somebody with ectopic. Janet asks, is dizziness a typical symptoms of hypercortisolism? I would say no. Dizziness is more a symptom of low cortisol than high cortisol. Sharon asks, if ketoconazole works well for 3 weeks and then stops working, is a sign that to go up with the dose? Yes, I think so. First of all, people can cycle and they might be in a higher dose after the 3 weeks, and they might be cycling through a high, or it may be breaking through. So set up an appointment with me and we can talk about going up on your dose. Anna asks, what is the best option for me who had pituitary surgery within the last 3 months? Have trouble keeping off hydrocortisone. Probably just stay on hydrocortisone. So, most patients can get off hydrocortisone. Sometimes it takes up to a year, sometimes even 2 years. I have a few patients that are on permanent hydrocortisone. I think probably 3 of them potentially. But most people can get off of it, but it may take time, and there's no rush to get off of it. Do any of these medications affect hepatocellular adenomas? I guess that's liver cancers. I don't think so. I haven't seen any literature on that. How do you measure ketoconazole success if you're cyclical? So because it blocks your cortisol at night, you can pretty much take it even if you're not in a high. Occasionally people get adrenal insufficiency if they're cycling through a low, but most people do okay on it even if they're cyclical, as opposed to Corlym, which I think you can't do at all in people that are cyclical. So you do by symptoms. You could follow urinary free cortisols or serum cortisols or ACTH levels. For cyclical Cushing's, is medication a less risky option? Yes, I'd say I am on metiraprone, which again is the same medicine as Isturisa. Metiraprone is more readily available in Europe. Metiraprone might be available. I think it might be available for, testing, might be available for long-term use, but in general, if you're in the United States, you probably should go on Isturisa. She's had great results with lower blood pressure and tachycardia improved. Great. She's still battling other symptoms. Again, I would make sure you take your metiraprone at night. You need to have other hormones looked at, thyroids and growth hormone and testosterone and all those looked at. But it's metiraprone's a reasonable drug if you're in Europe, especially. Sharon asks if you go up and up on the dose of ketoconazole, get relief each time, and then can't go up anymore, then what? Then I'd probably add this Teresa to it or consider surgery. As I said, I usually maximize the keto at 1,000 to 1,200 milligrams. If you haven't spoken on cabergoline or Dawson, next you tell us your thoughts on about this medicine's lower cortisol. I did mention that. It does work, but only in about 35% of the patients. It's worth a try. It doesn't have that many side effects. There was some concern initially about affecting your cardiac valves, but I think that's not been the case. It's a good medicine. I would probably use it in combination with another medicine like ketoconazole. Can maybe potentially shrink your tumor. Marissa asks, I haven't been officially diagnosed with Cushing's despite having several of the main symptoms and having a pituitary adenoma. I have been on cabergoline for elevated prolactin with no success. Would any of these medications be recommended? I've seen nearly 10 doctors who have not helped me or just tell me I'm fat, even though I have symptoms that occurred before my weight gain. I'm happy to see you, definitely, Marissa. For your testing, you may want to stop the cabergoline. Because it can lower your cortisol. So if you're doing testing for Cushing's, I probably would stop it. I think you might want to go on if you have some high cortisols, you might want to go on ketoconazole instead of the cabergoline. The cabergoline should shrink a tumor if it's a prolactinoma, but should not shrink a tumor if it's, or at least not significantly shrink a tumor if it's a Cushing's tumor. I'm sorry, if it's it should shrink a prolactinoma, but not shrink a Cushing's tumor. Tiffany, do you want to start a few from Facebook now, and then we'll come back to just YouTube? Great questions, everybody. Tiffany, you're still there?
There we go. Sorry, I can't unmute myself. Okay, so we had a couple comments and a couple questions. Amanda said, Isturisa and keto is giving me back my life after 2 failed PIT surgeries. This is such good info. Thank you, Dr. Friedman.
Thank you. I'm glad I'm helping you.
Yeah, Cherry asked, keto did fabulous for me at first, lost 6 pounds the first week, slept all through the night, night sweats and hot flashes went away. Then I had liver toxicity. I was taken off keto. This is my second pituitary tumor. I was told my test results aren't high enough to do another surgery. I am episodic. What is the best option for episodic patients?
So first of all, come see me for sure. And then I would make sure you take the vitamin E and the milk thistle when you take your ketoconazole. Probably start back at a lower dose and see how you do on the lower dose and watch your liver function carefully while on the vitamin E and the milk thistle. You might want to just start at 200 milligrams.
And she added that she forgot to add that her first PIT tumor was an ACTH producer.
So that is a Cushing's tumor. So that does
Right.
consistent with Cushing's.
Okay. Kathy said, had my endocrinologist on board the whole time on Coralin, baseline and routine US and DNCS kept Heister out of the picture.
I'm not sure I understood that one.
I don't know what either.
Maybe
So
repost that one later.
yeah. But that's all we have for now.
Okay. So keep on in the Facebook, keep on posting your questions if you will get to them. Sharon asked, does keto interact with topical antifungal creams or steroids like from dermatologists? Probably not. The fungal creams are topical, don't really get absorbed that much. There are itraconazole, which is like ketoconazole, but it doesn't block the cortisol synthesis as much. It probably blocks it a little bit, but not as much as ketoconazole. Steroids in general, you have to watch out for. If you are taking some steroids, you can get a bit of a cortisol if you take enough of them. So I usually have, people, a small dose of a steroid is probably okay, but people shouldn't take a lot of them. Lucy said, hello from New Zealand. I've been on Metiroprone and carvedilone for 4 years after a failed pituitary surgery. It works very well for me. I block and replace with 4 grams of Metiroprone a day. Repeat surgery is too risky for me due to the location of tumor. I don't want radiation or BLA because I have to travel internationally for my job. I have my MRI checked for tumor growth as Metiroprone elevates my ACTH. What is the longest time you had a patient on Metiroprone? Sounds like you're doing quite well. And I think the combination of Metiroprone and carbergoline is great. Again, I would take most of your Metiroprone at night if you're not already. Hysteresis is a pretty new drug, so I haven't used it for long terms, but I think you're doing fine. I would probably just stay on it for a long time. I'm happy to do a Zoom call with you and fine tune your things, but it sounds like you're doing well. And I think you're a great example of somebody who's doing on medicines instead of surgery. Sharon asks, when you decide to add hysteresis to ketoconazole, either the ketoconazole is not working or you're getting side effects from it. So patients, report that they're still wired at night and having their Cushing symptoms. I would add the hysteresis. I had a patient today I just finished talking to. We decided to do that. Can keto raise blood pressure since it's similar to levothyroxine, levo-keto, which let's say has a side effect? It can. I don't see that much, but and maybe the levo-keto is worse for that, but it occasionally can. But probably it's the patients that are having high cortisol, high blood pressure from their Cushing's. iPhone 13 asks, when you prescribe keto, do you have people stop the keto before further lab testing, or do you have people do labs while on keto? So for liver function tests, you should certainly stay on the keto. If you're testing cortisol, again, I stop it for 2 weeks and then do the testing and then restart it back again. I do sometimes do a urinary test on a urinary-free cortisol, but not the 17-hydroxysteroids, or a salivary test or a couple salivary tests on the keto to make sure that they're, the cortisol's come down. I have one patient that, he seems to still have high UFCs on the keto, even though he's doing well, and he likes to check it all the time. But I usually don't do that. I usually sort of false symptoms most of the time. Sharon says, I've been taking almost the max dose of keto, but it's not working. Would going off and restarting the keto help get benefits? Probably not. If you're on near the maximum dose, I think you should consider adding hysteresis or surgery. Anna says, is sweating a sign of high or low cortisol? Probably high cortisol. Or menopause and other issues. I had pituitary surgery in January 2024 for confirmed Cushing's to remove the tumor. Currently on hydrocortisone, but trying to taper off. I break out in sweats. It's hard to tell. We could, if you want to set an appointment with me, we can discuss that. But it might be menopausal issues. It might be, it potentially could be still high cortisol. I think you need to get tested. What is your cortisol level in the morning after holding your hydrocortisone for 24 hours, for example. AKMCD, why would a free T4 lab and HPLC free T lab differ? Both are taken at the same time. They are a little bit different methodologies. One is by RIA and HPLC is by HPLC. But they shouldn't be that far different. TSH low in range and reverse T3 above range. What would you recommend lowering the thyroid hormone? I would recommend, I don't know, it depends on what the free T4 and free are, if they're high or low, and the free T3, but you want to get them all. If you do have a high reverse T3, and I've had some webinars on this before, maybe we'll do another one next time on that. Probably lowering your T4 and increasing your T3 would help lower your reverse T3. RB says, does keto interact with trazodone? It does a little bit, so I think I would probably decrease your trazodone to 25 milligrams instead of 50 milligrams if you're concerned about it. Trazodone and many drugs do lower your cortisol, so if you are testing, you should probably try to not be on those medicines. Trazodone probably has a fairly minor effect, but it does can affect it. Allison asked if material didn't work for me, would Teresa work? Probably not. But I think again, we might have to use it in combination with ketoconazole, or consider a lower dose. But Teresa and Teresa really are the same medicines. How often does AI happen in patients using Isturisa? Again, if you take it at night, I don't think you get that much AI. But Isturisa is more potent than ketoconazole. You can get adrenal insufficiency on it. It might be worth having, again, the hydrocortisone on board. Sharon asks from Australia, from the above question of Tirapone, thank you so much for useful information. Do you recommend any natural supplements that could be helpful? Yes. So there'll be the vitamin E and the milk thistle to help protect your liver. Be two examples of sort of natural supplements that are quite helpful to help protect your liver. Tirapone, it's probably a little less likely to affect liver than keto does, but there's some reports of the hysteresis certainly that that can give liver function tests, and they recommend monitoring liver function tests. So taking the vitamin E and the milk thistle. Tiffy, any other ones you have?
Nope.
Nope.
But Sharon did a direct message, but she said it again. Would keto or hypothyroid be more likely to cause irregular menstrual bleeding?
So I've had a patients on keto that have irregular bleeding. In general, overall, people with endocrine problems have less bleeding, and people with fibroids and cysts and polyps have more bleeding. But I seem to have some patients that are on keto and they get extra bleeding just out of the blue. It's worth seeing your gynecologist and doing an ultrasound if that happens. Hypothyroidism, more severe hypothyroidism can give you menstrual irregularities and extra bleeding, but not that common. Does keto interact with St. John's wort? I'm not sure the answer to that question. I haven't seen that. What else, Tiffy?
I have one more. Alyssa asked, how high is ACTH in tumor? I have high DHEAS, high cortisol, high ACTH, but normal response to DEX suppression.
So I don't find DEX suppressant that helpful of a test for mild Cushing's. So I would make sure you do your urine-free cortisol and your salivary cortisols. High DHES can be seen in both PCOS and in pituitary Cushing's. Adrenal Cushing's usually have a low DHES. So you might want to also be looked for PCOS with your high DHES. Would keto or hypothyroidism be more likely to cause irregular menstruals? We answered that one.
You answered that, yeah.
Did you test folks on keto or have them wait 2 weeks before testing? So the liver test should be on keto. Most of the time I test, and I always check a cortisol and ACTH on keto. The ACTH should go up and the cortisol should go down a little bit, but not always that often. Sometimes if somebody feels like they're breaking through the keto and I'm not sure, then I would test them. If sometimes you can't tell if you're in a high or low, I would probably test them with a urine-free cortisol or salivary cortisol. And then if still I'm waiting to diagnose somebody for Cushing's and I want to do more testing, I have them stop it for 2 weeks, restart the testing, do the testing for 2 weeks or so, and then restart the medicine.
Okay, I have one more question from Sherry. What is the current testing protocol for episodic UFCs? Never worked for me.
So episodic, the key thing is to test when you're in a high. You can look on my website. I have some handouts on when to test for a high. Wired at night, can't sleep, stretch marks darker, buffalo hump bigger, insomnia, and not the lows. You can't get out of bed. And I usually do salivaries and urines. The salivaries are probably a little easier to do. I don't recommend marathon testing. I recommend just doing like 4 to 8 salivaries when you feel like you're in a high, and try to do a little diary. And if you get a high, you can go back and then retest.
Great.
AKMCD, AKCD says, I'm not on T3. Free T4 was 1.1. Free T4 was 1.7. Get palpitations off, and TSH is low range. Reverse T3 is high. I am AI, but I learned so much from your previous whereas previous endos wrote me off, and I'm your patient. We could talk more about your thyroid tests, once you at your next appointment. In general, you might want to back down a little bit on your free T4 if your reverse T3 is high. But I think we have to look at the whole picture. Sharon asks, have you seen any difference in surgical cure rates based on the location of pituitary tumor, like to the edge or directly in the middle? Not really. I think As long as it's one tumor, it's easier to operate. I have these patients that either have like a barbell type of tumor or multiple tumors. It's also harder to operate. The people with the hyperplasia is harder to operate on. People that are sort of invading the cavernous sinus, which I don't have too many people, those are harder to operate on. But I think if the surgeon sees a tumor and takes it out, people have a reasonable chance to cure. What are the symptoms of pituitary Cushing's? So Cushing's disease, pituitary, as well as other types of Cushing's, have weight gain, fatigue, poor sleep, low libido, low muscle strength, especially your proximal muscle strength. You have trouble standing up or squat, trouble combing your hair. You have bruises, stretch marks, thin skin, central obesity, weight's mostly in your stomach with weight thinning of your extremities, menstrual irregularities, low libido in both men and women. So those would be some of the symptoms of pituitary Cushing's. ADS, I've been on Respreeza for a month now and I still have high blood serum levels with some of my symptoms improving, but not all. Do I need to keep up in the dose? Yes, I'd probably increase the upper in the dose and consider adding the ketoconazole back with that. Jamie asks, are pituitary tumors more likely to be on the outside of the gland, pituitary or inside the gland? They're always inside the gland. They're pituitary tumors. I had 2 patients potentially that had some like a nasopharyngeal tumor, but it's usually a pituitary tumor.
One more question. Lori asked, how long should testing be done to confirm Cushing's? Currently, I have a high cortisol, high ACTH with no confirmed Cushing's with a year of testing.
So, I would do your urinary-free cortisols and salivary cortisols when you're in a high. Again, I'm happy to see you if you're not my patient already. The testing is Cushing's disease is high cortisol, so you have to have some positive tests before you move on to it. Now you like to to have positive tests before the medicines.
Thank you.
Melissa, I have a lot of those symptoms that you mentioned for pituitary Cushing's. My cortisol at the low end. My endo says it can't be Cushing's. So Cushing's disease is high cortisol at night. So you can have a low cortisol in the morning. So I don't know if you've done salivary cortisols, for example, at night. If you do a 24-hour urine, it might be canceled out by low cortisol in the morning and high in the evening. So I would probably do some salivary cortisols for that. But you do need to have high cortisol. Marissa says same as Melissa, so do your testing at night. Sharon asks, how long does it take to get surgery once you recommend a patient to the neurosurgeon? It depends on the surgeon, it's time of the year, but a month or so is probably pretty reasonable for Dr. McCutcheon, for example. Is it possible to have Cushing's but have blood work specifically be in normal range? Urines and salivaries are hard. Yes, so the cortisol for blood cortisol is not helpful for Cushing's, especially morning blood cortisol. It's pretty similar between Cushing's and non-Cushing's. I did a study on that when I was at the NIH and one of my first papers. So Cushing's disease of high cortisol at night, so your salivaries are usually high, your 24-hour urines are high, but your blood cortisol is pretty normal. Do you test midnight blood work? Yes. So in my clinic, we come on Tuesday night, Eric's there late, so we can do a midnight blood cortisol. It's hard to get in many places, but potentially in the people can go to an emergency room, urgent care, and they can get it. They can get a midnight cortisol done. How many different types of high cortisol readings do you need for the diagnosis? Speaking as someone now with a high salivary, but urines keep coming back a little normal. I do like to have 2 categories that are high, either your salivaries, your midnight blood cortisols, or your urinary cortisols, your 17-hydroxysteroids. I like to have 2 tests high. The higher they are, the more likely. And somebody, with 1 high consistently, I might put them on the ketoconazole for a while, see if they get better, and then consider retesting for that other one that's not high once on the ketoconazole. We'll take one more question. Tiffy, you got anything else? Sharon asked, what are your thoughts on high urine spot urine test? So I used to do a 10-hour urine from 10 p.m. to 8 a.m. And then we did LabCorp, got like a bunch of volunteers and they tested the volunteers and they were very similar as my Cushing's patients. So I stopped doing that test. I've been trying to I would probably do a spot nighttime cortisol and a urine cortisol, not a morning one. And I've been talking to LabCorp when they had the old representative of LabCorp was pretty helpful. The new ones I haven't really talked about it. Okay, everybody says thank you. It was a pleasure talking to everybody. Hopefully I answer your questions. Again, I'm happy to see you, the people that aren't my patients in clinic, and we'll catch you later.